Hi everyone, thank you for joining us today for this important topic. I'm Jessica Stewart, Executive Director of the Family and Community Services Insights Analysis and Research branch, also known as FACSIAR in the New South Wales Department of Communities and Justice. And welcome to this month's Lunch and Learn research seminar on preventing and responding to self-harm and suicidal ideation, latest research and best practice for children and young people in care. Before we begin, I would like to acknowledge that wherever we are joining from today, from across New South Wales, we are all living and working on Aboriginal land that was never ceded. I'd like to personally acknowledge the Bidjigal and Gadigal people of the Eora Nation, who are the owners and First Nations people of the area where I'm joining you today. I'd like to pay my respects to all First Nations elders, past, present, and to future and emerging leaders. And I'd like to extend that respect to any Aboriginal and Torres Strait Islander colleagues joining us today. I'd also like to acknowledge people who have a lived experience of self-harm and suicide, whether that be personally or in the care of someone. I acknowledge the distress this would cause and the ongoing journey that encompasses. I'd also like to warmly welcome everyone who is joining us today. We've had more than 1,300 people register, which is more than any of our previous Lunch and Learns, and really just demonstrates the importance and interest in this topic. So thank you so much for taking the time to be with us today. At today's Lunch and Learn webinar, the presenters will share the latest research about self-harm and suicide and child maltreatment from the New South Wales Child Development Study and Australian Child Maltreatment Study. Information will also be presented on how to respond to self-harm and suicidal ideation, as well as practice guidelines for children and young people in care. We're aware this is a sensitive topic that we are discussing, and we'd like to ensure that all attendees today are able to access support if you become distressed at all. So we'll be posting a link in the chat at regular intervals with relevant resources which may be of assistance. And for DCJ staff, please contact the Employee Assistance Program who have been notified of the webinar. And following the presentations, we may have some time for questions and answers. So if you do have any questions or comments, please put them in the chat and we'll either respond to them in the chat or we will discuss them during the question and answer time. So I'd now like to introduce our presenters for this afternoon. Holly Erskine is an adjunct associate professor with the School of Public Health at the University of Queensland and is an affiliate associate professor with the Institute for Health Metrics and Evaluation at the University of Washington. She leads the Child and Adolescent Psychiatric Epidemiology and Services research stream at the Queensland Centre for Mental Health Research. Holly is the principal investigator of the National Adolescent Mental Health Surveys and is also a chief investigator on the Australian Child Maltreatment Study and the Centre for Research Excellence in Adolescent Health Metrics. Dr. Divna Haslam is an endorsed clinical psychologist and academic working in the area of child adversity at the Queensland University of Technology. Her research focuses on how to identify and prevent child maltreatment. Through informing policy and practice, she aims to ensure all children have access to loving, stable, violence-free childhoods to enhance mental health across life. Melissa Green is a professor at the University of New South Wales in the discipline of psychiatry and mental health and group leader in stress-related psychopathology at Neuroscience Research Australia. Her research aims to understand the interaction between social and biological determinants of mental disorders from a developmental life course perspective. Melissa leads the New South Wales Child Development Study, a multi-agency longitudinal record linkage study of more than 90,000 children who are growing up in New South Wales, which seeks to inform policy and practice using Australian population data. And Kelsey Stalker is an occupational therapist who works within DCJ's Links Trauma Healing Service with young people in out-of-home care. Kelsey is from New Zealand and has a background in suicide prevention and dialectical behavioural therapy with young people and families. She's previously managed a suicide prevention service through New South Wales Health and is incredibly passionate about supporting services and communities to improve our responses to people experiencing suicidal distress. After the presentations, we will hear from Marjorie Anderson, the National Manager of the Aboriginal and Torres Strait Islander Crisis Services at 13 Yarn, and I'll introduce Marjorie when we come to this part of the program. So thank you so much to all of you for joining us today, and please go ahead, Holly and Divna.
Thank you so much, Jessica, and thank you, everyone. It's really a delight to be here today on behalf of the Australian Child Maltreatment Study, or the ACMS, with my colleague, Dr Divna Haslam, presenting on some of the findings about the association between child maltreatment and suicide. So just very briefly, the ACMS was a survey of 8,500 Australians aged 16 and over. It was a random sample, so people were contacted randomly via telephone during 2021. Most importantly, for this particular presentation, we did what we call oversample, 3,500 adolescents and young people aged 16 to 24 years. And they are some of the findings that we'll be presenting on today as well. Also, just to mention, so this was a survey. So this is people reporting their experiences as related to specific measures. And I can't go into too much detail, obviously, but just to emphasize that these measures were really comprehensive. It wasn't just a handful of brief questions about someone's experience. It was quite in-depth questions about child maltreatment, mental health, suicide, self-harm, and a range of other measures as well, many of which have now been published on. So the findings in relation to child maltreatment more broadly, it is disturbingly common among young people, aged 16 to 24 years. Almost 60% of our young people aged 16 to 24 years have experienced one or more types of maltreatment. And you can see that that is higher in women, almost 2/3, as compared to men, who are still well over half. So the prevalence of specific types of maltreatment among our younger age group, 28% physical abuse, over a quarter have experienced sexual abuse, emotional abuse among the highest, so over a third, neglect around 10%, and exposure to domestic violence over 2/5. And 40% have experienced multi-type maltreatment. And what we mean by that is that they've experienced more than one type of maltreatment as well. So I'll just linger on this slide sort of as long as I can, because really these findings do take a moment to digest because they are so confronting, but they also demonstrate some real opportunities to intervene and improve well-being as well. So I'll finish off my section looking at the association between child maltreatment and self-harm in the past year. So that's the 12 months prior to the survey being conducted. And as you can see, there are some quite apparent differences between those who've experienced child maltreatment and those who haven't. So among those who haven't experienced child maltreatment, self-harm is around 3%. If we look at self-harm among young people who have experienced child maltreatment, we're looking at 14.3%. So getting close to almost 5 times higher. When we look at this by gender, we see sort of a similar story as well. If you were to combine those two top bars, so no experience of maltreatment versus those who've experienced maltreatment, it's what we call a statistically significant difference. So that's beyond probability. And also among those who have experienced child maltreatment, significantly more females than males have self-harmed in the past 12 months as well. So this really starts to indicate that child maltreatment is something we need to look at quite seriously in presentations of self-harm. And I'll now hand over to my colleague Divna to discuss suicide and some of the additional implications.
Thank you, Holly. So as Holly said, we kind of looked at young people 16 to 24 years old, but we did also, as she's mentioned at an early stage, look across the lifespan. And so I'm going to present just the data on suicide for the young people, but I will just mention that these findings that we find in terms of the association between self-harm and young people being much more common among those who experience maltreatment persist right across the lifespan. So when we're looking at people that are 45 plus, 55 plus, it's really impossible to find somebody that's self-harming unless they've had an experience of child maltreatment. So these data and these differences are significant not only in youth but right across life. So Holly's already covered off the kind of past year self-harm. Obviously, that's a fairly high percentage of people that are in experiencing self-harm that have a history of maltreatment. Let me now present the data on past year suicide attempts. So again, these are kind of underrepresentations of overall impact of suicide, because we're only looking at the past year. And of course, some people that have experienced suicidal ideation or attempted suicide have done that some time ago. Again, we see this really clear difference that Holly found in this self-harm. So people that have no history of child maltreatment are almost 0.5%, or just about 0.5% of those people have experienced past year suicide attempts, compared to 5.2% of those with self-harm child maltreatment history. So we're looking at about 8.5 times more likely to have experienced a suicide attempt if you've had child maltreatment history. On the other side of the screen here, you see this really nice clear gradient of what's happening. So among males that have experienced no maltreatment, that's the 0.6. So really, we're not seeing any females. This NP stands, we didn't have enough females that actually had no experience of maltreatment but had attempted suicide. So from a policy point of view, that tells us that people, females, particularly girls attempting suicide, are very, very likely to have experienced child maltreatment. So from a public health perspective, that's an important message. In terms of the experience of maltreatment, again, we see these gender effects that Holly had kind of talked about earlier. So males have experienced child maltreatment, 3.3% have experienced or attempted suicide in the past year, and females 5.8%. So we're seeing a kind of double whammy for females there. They're more likely to experience certain types of child maltreatment, and also more likely to attempt suicide. And of course, those of you will know that there's some discrepancies in the gender in suicide literature about completed suicide. So obviously the caveat, of course, is that we're just reporting people that are still alive to tell the story. Here we see the odds ratios, and for anybody that's not familiar, this is just a measure of association. And so anything of these numbers on the side here that are above a 1, we say is more associated with maltreatment. So self-harm, we see overall 3 women and men that have experienced any type of child maltreatment are 3.9 times more likely to have self-harmed in the prior year. When we're looking at suicide, we also see that same strong association. So people that have experienced child maltreatment are 4.6 times more likely, or have higher odds of attempting suicide in the past year. But the other key finding here is this gender effect. So women in particular are much more likely to have attempted suicide than males, even when they've actually experienced child maltreatment in the past. So it's kind of important findings there in terms of gender effects. We are reporting on gender diverse people in a separate paper, so stay tuned for that. We can't present that today. The other key finding that we found was when we kind of narrowed down into looking at not just any experiences of self-harm, but which particular ones were most damaging or most associated with self-harm and suicide attempts. We find that sexual abuse here and emotional abuse are the ones that are the strongest predictors. And these odds ratios are after accounting for any other types of maltreatment. So it accounts for co-occurring physical abuse, neglect, and other things. So really a key takeaway is that associations between self-harm and suicide are much greater when they've experienced child maltreatment, but particularly if they've experienced sexual abuse or emotional abuse. So our implications really are that it's associated with maltreatment, which is not a surprise. Particularly, there are strong gender effects, and emotional abuse and child sexual abuse are particularly important. We've done a good job of dealing with sexual abuse, but not really paid a lot of attention to emotional abuse. So I think that's really one of the key public health and policy frontiers that our work should kind of drive moving forward. And of course, the prevention of maltreatment must become a fundamental part of prevention initiatives for self-harm and suicide. So we really can't ignore the childhood histories of what's going on. And I think Professor Green is going to be talking more about that in just a moment. And finally, we would argue that as well as prevention, we need good intervention services to try and target and reduce the impact of early maltreatment across the lifespan. So I'll hand over now to Professor Green, who's going to be talking about her linked data, which is a slightly different perspective, but complements our work really lovely.
Thank you very much. I'll just move to my slides. So thanks again to everybody for organising today. I'm coming to you from Gundungurra country up in the Blue Mountains today. I'm going to talk to you about a couple of studies that we have undertaken within the New South Wales Child Development Study focused on self-harm and suicide prevention. For those of you who aren't familiar with the study, I'll just take a moment to explain because it's very different in terms of methodology to the work that you've just heard about. We use administrative data from governments for a child cohort of over 91,000 children and their parents. And so you can see from this slide, we have undertaken 3 waves of linkage so far in this study, bringing data up to the age of 18 years for the child. And the data spans all the way back to 1971 in the case of some of the DCJ data. Not all records go back that far, but we gather as much information as we can from health, justice, child protection and education for these children and their parents, link it all together and try to understand what's going on across their life course in terms of the developmental trajectories for mental disorders. And in this case, we're looking at self-harm and suicidal ideation. So I wanted to talk to you today just about 2 papers that we've published. One of them was in the MJA earlier this year and another one in the Australian and New Zealand Journal of Psychiatry. So I'll just walk you through some of the most important findings from those 2 papers. So here's some information from the first paper published in the Medical Journal of Australia. In this paper, we used only the health service data to try to detect self-harm or suicidal ideation. And we were interested to look at the connection between a child being reported to child protection services and the level of contact or service provision they had with child protection services and how that might be related to their likelihood of self-harming or having suicidal ideation or behaviour recorded in their health records. So a couple of the main points, I mean, there's some detailed information in the table here about our sample size and the characteristics. But over here, I just wanted to point out that overall, among our sample of 91,597 children, only 2.4%, so just over 2,200, had any record of self-harm or suicidal ideation in their health records by the age of 17 years. They were more frequently recorded for girls than boys, so 3.4% of girls and 1.5% of boys had at least one record of self-harm or suicidal ideation. And more than 74% of the children with at least one self-harm incident were known to child protection services in New South Wales. What this paper also showed, oh no, I think, yeah, no, sorry, I have jumped. Sorry, what this paper also showed was that there were, when we looked at the different level of service that was provided to children, so these are mutually exclusive groups of children who have been placed in out-of-home care as their highest level of service from the Child Protection Agency. They're represented in blue. In red are children who had a substantiated report of child abuse or neglect as their highest level of service, so they were never placed in care, but their maltreatment's been substantiated. And in yellow, we have children with a non-substantiated threshold report, and in grey, no child protection contact. And what this is showing you is that the children in out-of-home care had a higher rate of self-harm and suicidal ideation starting at an earlier age than the children with the substantiated or non-substantiated reports. And if I show you that another way, this is just telling you that by the age of 17 years, 13% of children who had been placed in out-of-home care at any time before that age of 17, 13% of them had a self-harm or suicidal ideation record in their health records. Whereas by the age of 17, it was 10.4% of kids with a substantiated ROSH report and only 4.6% of kids with a non-substantiated or non-threshold report who had been found to have a self-harm or suicidal ideation record, compared to a very low proportion of kids who have had no contact with child protection services and who are then showing very low rates of self-harm and suicide in the general population. So that's the upshot of the first paper, just showing what you heard from the previous speakers about this extremely strong association between being maltreated and having incidents of self-harm and experiences of self-harm and suicidal ideation. Moving on to the second paper, this takes a different tack and uses all types of government records to try to look at the rates of self-harm and suicidal ideation. So not just focusing on health records this time. We looked also in police records and in DCJ's child protection records, where it can be recorded by a caseworker that the child is experiencing self-harm or threatening suicide as part of, the follow-up for a child who has been reported to Child Protection Services. So we were interested to do this because of the idea that maybe not all of these incidents of self-harm and suicidal ideation or behaviour are even making it into the health services that we have the data from. So when we looked across all of these different types of social and health records, we actually found over 5,200 children who had at least one incident of self-harm or suicidal ideation in any of those records. So that was an increase in what we obviously found in the previous paper that was restricted to health records. Now, interestingly, of these 5,212 kids, 3,514 of them, or 67% of them, actually had their records of suicide or self-harm in the Child Protection Service records rather than the health records. For a further 3,198 of those kids, or 91% of the ones that were known to Child Protection Services and found to have self-harm in their child protection records, 91% of them, this was the first time that any self-harm or suicidal ideation had been recorded for those children out of all the types of records that we spanned. It was also interesting to note that of the children who we found self-harm or suicidal ideation recorded in their child protection data, the majority of them had had no contact with health services either before or after. So about 73% had had no other contact for this self-harm or suicidal ideation. And that's a big red flag, I think, for, again, a public policy piece of advice that children who are showing up to child protection with these incidents recorded really need some follow-up care. Perhaps some of them got placed in care later and, didn't end up needing health services, but it's a stark statistic that only child protection is getting this information, the health service is not. And girls were more likely than boys to access health services, but not the social services. So there was an equal number of boys and girls being recorded by police with self-harm and suicidal ideation. And in child protection, it was almost equal for girls and boys, but it's showing that boys are not accessing their health services as they potentially should. And we know that while girls attempt suicide more, boys more often succeed in their suicide attempt. So these are other messages we need to get across about where to find these boys that are at risk of self-harming. It may not be in health services that they're first or ever appearing. The other piece of work that we did in this paper was to look at the age of first contact for self-harm or suicidal ideation, dependent on which record sets they were found in. And so here the colours in the graph depict the record set. Blue is the child protection records. Yellow is the emergency department records. Orange is inpatient admitted patient records. Red is mental health ambulatory. And down here in grey are the police records. What this graph is showing you very clearly is that the self-harm recorded by child protection data is starting very early, on an average age of 13.8 years as being the child's age at the time of their first contact with Child Protection Services when self-harm is being found or recorded. Whereas for the police, the average age was over 16 years, and for the health services, the average age was about 14 years. So again, some messages here for how to find and detect as early as possible children who are at risk of self-harm and suicide. So the policy and practice implications here are that suicide prevention is absolutely not solely the responsibility of the health services, but does require a whole of government community approach to prevention. It seems that child protection services once again are finding themselves at the front line of a response, in at least here being the earliest age at which children are being recorded to have a self-harm or suicidal ideation incident. This means that caseworkers and obviously the police as well, who are sometimes the first to turn up to these events, really need to be adequately resourced to respond to self-harm and suicidal ideation in young people. And that we need to explore opportunities for earlier intervention beyond health services, so that perhaps, you know, if there's real-time data sharing amongst all of these government agencies, then there could be an earlier response provided by those who first come into contact with these young people before they get to the point that they've succeeded in such an attempt. So just to acknowledge briefly all of the people involved in the study, and particularly Kirsty O'Hare, the first author of those 2 papers that I've just presented to you, but this is a huge effort of a lot of people over a long time, and I want to acknowledge our custodians as well. So thank you very much. I'll hand over now to the next speaker.
Wonderful, thanks Mel. So before I jump into some practice implications for the information we've heard, I'd like to echo Jess's acknowledgement, and I'm coming to you from the Wabakal country today. I'd firstly just like to acknowledge the heaviness of this topic, as well as the context in which suicide and self-harm is so often held within our society. It's a really highly stigmatised topic that people often shy away from talking about. And because of this, we don't often accurately understand what drives suicide and self-harm and how to help. So I'm going to start today by debunking some myths around suicide and self-harm so that we have the perspective to respond differently. Then I'll provide some ideas and tips around how to have conversations with someone who either is experiencing suicidal distress or you think might be at risk. So first of all, I just like to fly through a few common myths here that do create a bit of stigma. Firstly, whilst a diagnosed mental illness is most definitely a risk factor for suicide, the most common risk factor grouping are actually psychosocial factors, so things happening in people's environments. My take-home point is that people who are experiencing suicidal distress don't typically look like they do in the movies, and this is especially so in young people. It isn't necessarily someone who's in bed all day and crying a lot. There's many other signs that we need to take note of. Secondly, as we've heard, suicidal thoughts and behaviours are more common than we think. They impact around 1/3 of youth generally, and as we've just heard, those statistics are significantly higher for young people in care. So it's important we ask about suicide when someone's distressed. There's also a lot of stigma around self-harm. And firstly, research does tell us that self-harm is linked with suicide. It's not attention seeking, it's an indicator that someone's distressed. In saying that, self-harm doesn't automatically indicate that a person intends to end their life. And there's many reasons why people self-harm. I hold the perspective and encourage you to do the same, that people are trying their best to meet their needs. This could be managing their distress, communicating their distress, or trying to escape the distress. But we do need to remember that distress is at the core of it. The only way we'll know what's driving behaviour is to have conversations and not to be punitive. We need to know the why to provide support and help people learn different skills to manage their distress. So in my previous slide, I spoke about psychosocial risk factors being the most commonly recorded risk factor grouping when people have died by suicide. And the orange bubbles on this slide are the most common psychosocial risk factors for young people in Australia. At least 2/3 of all deaths by suicide had at least one or more of these risk factors identified. So we know that the presence of these issues in someone's life increases the likelihood of suicidal behaviour. I want you to take a moment to look through these factors and reflect on the presentations we've just heard, thinking about young people specifically in out-of-home care. Like, they experience so many of these factors, and it's also likely that they've had less support to manage these situations by going through attachment disruptions or losses of key support people, and less opportunities to build the skills to manage these situations. This can kind of really feel lonely and hopeless for young people, and those things are both linked with suicide as well. So as a result, we know young people who have had contact with the child protection system are significantly more likely to engage in suicidal or self-harming behaviour. But here lies a bit of an opportunity, and I really want to encourage everyone to see support sort of more holistically. So effective support involves seeing and responding to the whole iceberg. So often when we talk about suicidal distress or a crisis, we focus on what we can see on the surface, the tip of the iceberg. We need to focus on what's beneath the surface as well. The factors driving suicidal distress are often harder to see and not situations where there's a quick fix. We need to stay alongside a young person to help them to navigate these incredibly distressing life events so that the likelihood of ongoing suicidal distress is reduced. So on my next few slides, I'll talk about how we can respond to a crisis and help to target some of those psychosocial factors. I've pulled together current research and frameworks around suicide prevention, cultural frameworks like the SU, and combined this with my own practice experience to provide some information around how to respond to someone in distress and best stay alongside them in that journey. My advice is by no means exhaustive, and I really do encourage everyone to look up further information. And I've got some great sites listed at the end of my slides. So first of all, I'm going to cover what we need to do in a crisis, and I've split these up into 3 key steps. And here I'm not talking kind of clinical assessment on the first point, but a chat that can get an understanding of where someone's at. Historically, professional support's focused on risk prediction, or something we call risk stratification, which is conducting an assessment and placing people at low, medium or high risk of harming themselves. And in the past, we've leaned on an endorsement of suicidal ideation, which is someone saying they are or aren't having suicidal thoughts, as the most important predictor of risk. We now know that this alone does not accurately predict risk. It's part of the picture, but we need to make sure we're looking at the whole picture. Research and consumer feedback now tells us it's much more effective to have a broader conversation with people. So as well as asking about someone's intention, method, and means available to hurt themselves, we also want to find out what's going on in someone's life, what's important to them, what's driving suicidal behaviour. So I do encourage people to ask questions around some of those psychosocial factors I mentioned earlier. As part of the assess component, it's important we differentiate self-harm and suicide. So remember, when someone hurts themselves, it doesn't necessarily mean their intention to end their life, but it does indicate a high level of distress. So don't make assumptions either way. The only way to actually know is to ask. Secondly, around action. Firstly, reducing access to means. We do need to lock up or remove means of self-harm in someone's direct environment. Things like medication, cords, ropes, chemicals, and sharps. This concept is called sort of means restriction, and it's often challenged. I've heard many statements like, if someone's intent on hurting themselves, they'll use anything, so there's no point. This is untrue, and we know from research means restriction is most definitely effective. So when people don't have direct access to means, it gives more time for people to ride out that peak of distress, which is really important for teenagers who can experience strong emotions and have a tendency to act more impulsively. So what means restriction does, it gives us more time for intervention or for someone's distress to lower and to think and problem solve differently. Some advice for professionals is, when speaking with adults who are providing care for suicidal people, we need to be really specific about what needs to happen when. So a statement like, if you're concerned or if risk increases, bring them to ED, that's too broad. We really need to be specific about what increased risk looks like. So for a person, that might be if they state that they're going to end their life, call the mental health line, or if someone's gathered the means, take them to hospital. So be as specific as possible. We also need to increase support and monitoring at these times. So be there, stay present, check in, and ideally work on how that looks with the person. For young people, communicate ideally collaboratively with the young person, but to their guardian and support people, and speak with young people about how they want that checking in to look. Sort of another kind of caveat here is if people say, don't tell anyone, but you believe they're at risk, you still need to act. I'd rather someone's angry at me and alive than the alternative. So do act as collaboratively as possible and negotiate how this happens, but safety's got to be paramount. And lastly, acute supports. So in an immediate crisis, do contact emergency services or support someone to ED. And if you're not sure, call the mental health line. The other thing to note is that suicidal behaviour does meet the criteria for a ROSH or a risk of significant harm. So make sure you do your mandatory report as well. So whilst the last slide was about what's sort of vital to cover at a time of crisis in a conversation, these points focus on how to have the conversation. So I acknowledge, present company excluded, these conversations aren't everyday ones for most of us to have. But they're important, and genuinely these conversations can save lives. Connections an antidote to loneliness. So firstly, I want to debunk another myth, which is asking about suicide does not increase the likelihood of suicidal behaviour. People worry about that happening, but there's absolutely no research to support this. There's research to the contrary, in fact, so please do ask. Secondly, getting to know someone, including what and who's important to them, provides key opportunities to figure out how distressed they may be. Ask about those psychosocial factors. How are things at school? What's happening in your friend group? How's your family contact going? What was the result of a sports game that was really important to them? If there's a significant issue in one really meaningful area of their life, or some disruptions in multiple areas, that can have a massive impact on the presence and intensity of suicidal thoughts. Secondly, this probably goes without saying, but try to be as non-judgmental as possible, and please take the phrase committed suicide out of your vocab. Talking about suicide and self-harm can feel really shameful for people. And some kids I've worked with have really struggled to communicate an increase in their distress, whether that comes from a communication disorder or from shame. So in safety planning, please consider that. You can, get creative, and in the past I've used sort of traffic light systems with carers and young people. So setting it up, so red means I'm struggling and need people around me, green means I'm going okay. Or a code they can text their carer from the other room, because maybe texting feels less confronting than walking out and having a conversation. So plan in advance with a young person and their support network around how to communicate if distress increases, how they'd like people to respond, who's best to talk to. Sort of write it down and get that plan happening. And my last point is it's okay to make mistakes. These conversations can feel really awkward and messy. I do encourage people to sort of practice how to ask with a friend or colleague. Whilst we've got the kind of "Are you okay?" posters sort of littered around our organisation, they're actually hard conversations to start. And people often worry they might inadvertently say something that triggers more distress. Like, it's very possible. I've done it many times. And it's okay. You can repair, say sorry, stay present with someone. Connection's the key. And I think if your intention is to help people feel that. And finally, what to do after a crisis. So historically, a lot of support eases off after a crisis. But as we know from that iceberg image and the psychosocial drivers of distress, the factors that fuel distress are often still present and need to be addressed. We need to keep walking alongside people and help them to build skills to flourish within their environments, and also increase the likelihood that the things they need to make them flourish are present in their environment. So I've taken the psychosocial drivers from the bottom of the iceberg and listed them under 5 key areas. So focusing on these areas can help to build what we call protective factors for people, so that when distress does inevitably come, they have more support and skills to manage it, and more hope that their life's worth living. So firstly, education is hugely protective. So research in both Australia and New Zealand tells us how important educational achievement and literacy is for young people. It has an established link to a decreased risk of death by suicide. So work with kids and families to keep them in school. Help them to navigate the barriers that may be impacting their desire to attend. So things like bullying, friendship issues, poor grades. Young people don't automatically know how to deal with those situations. So help them. So for example, practice with a young person how to ask a teacher for help when they don't understand a question and are highly anxious. Like, don't assume people have those skills. Secondly, around connection to culture. I'm a Caucasian Kiwi, so I'm by no means an expert here, but we know from Tracy Westerman, who's an amazing psychologist, we know from her work that a strong cultural identity for Aboriginal people decreases the likelihood a person will die by suicide. And we need to work with people on meaningful connection. So not just NAIDOC week attendance, connection to family, mob and country. And a strong cultural identity is having culture in your day-to-day. So when people are disconnected from their culture, they don't always know what connection could look like. So we need to lean on Aboriginal people and community to make sure we're getting this right, sort of bring people into that support network. Working with people to develop a broad social system, ideally in different environments, is also key. Help young people to build networks in their community outside of services, as well as use services for support. So help them go to the PCYC where they can keep accessing that by themselves, sports groups in the community, friends at school. So one of my sort of major take-home points here is the broader the connections, the more support people have. So if one support group ruptures, there's still other networks to kind of catch and hold people. And again, be mindful not to assume people automatically have the skills to navigate difficulties in this area. Like, young people don't often know how to navigate conflict or say sorry, so help guide them through this. And they don't automatically know how to walk up to a group and start conversations, especially if they're experiencing anxiety. So go with them or help them kind of walk into that PCYC. With someone's consent or involvement, it's also important to help to activate their support network when they're distressed. So whether that's kind of getting alongside them and calling their carer together or setting up those support systems. The fourth point, and whilst I'm clearly biased about this one because it's my job, psychological support's imperative and can be really effective for people. It can help to target the ongoing drivers of mood issues, trauma experiences or distress, and build the skills to manage big feelings. So I've got a list of a few places on my slides around how to access those services. And I'd also encourage that when you talk to kids about therapists, please debunk some myths. Like, it's not like the movies, and often that is a barrier to engagement. We're very approachable, I promise. Lastly, stay present and keep checking in. Keep asking how someone's going, and don't assume just because someone's smiling more and doing more that they're feeling better. Especially for young people in care, we've got to remember those psychosocial stresses are ongoing. So we've got to keep checking in. Here's some kind of ideas around support for both more information, individual support, support for carers or people caring for young people. Beyond Blue have a great app around safety planning that I'd encourage people to download, or caseworkers to have on their phone. And I will now pass back to Jess, who will also talk about, with Marjorie, hopefully, about another amazing service available.
Thank you so much, Kelsey, and really important and useful advice for people online today. So Marjorie Anderson, who's the National Manager of the Aboriginal and Torres Strait Islander Crisis Service 13 Yarn, is currently flying in the air and is unable to join us today. So what we will do is hopefully record a discussion with her and post this up on our website along with today's presentations. So we may move now to the Q&A part of the session with all of our presenters, and there has been a number of questions come up in the chat. So if you do have a question, please put it there. Also, some really positive feedback to all of you presenting, that this training is fantastic, well structured and delivered. So well done to all of you. The findings from research complemented with your advice, Kelsey, is really helpful. So There are a few questions in there about data, which I can see have been answered. There was a question around the use of the word committed, and a few people interested in that. Kelsey, are you able to talk a bit further about that?
Yeah, I think in the kind of sort of, I've worked a lot with kind of peer workers and people with lived experience of suicide, and it is a shift away from that sort of punitive, or I saw in the chat someone had mentioned about sort of a criminal sort of perspective on it. I think it just helps to frame it more. When we step away from the language, it helps to frame it more as a distressing event rather than something that kind of someone is doing and doing to kind of cause harm. I think it's distress driven, so that's probably what I took to there, Jess.
Thank you. There's another question, and it relates, Melissa, I think, particularly to your findings around us seeing records in child protection, and that being sort of the first port of call in terms of recording rather than in health services data. There's a question about how do you assist young people, and Kelsey, I'm sure you've got advice for this as well, who do not want to engage with a psychologist or counsellor, but how do we encourage young people to engage with health services and other services more?
I'm going to leave that one to Kelsey.
It's not the first time I've heard that. Yeah, I think you know, two things. It is really important in someone's choice to engage. I think often the more people are pushed to, I know this is me personally, you know, the less you kind of want to do something. But again, presenting it, often I really encourage people to present it like just, you know, a no strings attached first meeting with someone. If you don't like them, that's okay. Also, I like to frame kind of counselling and therapeutic support. Like, I don't like every physiotherapist that I go to isn't necessarily the right fit for me. So, you know, you've got to find the right therapist that fits your style too. But sort of debunking some of those myths, I think, is really important. It's, you know, I've never worked with a young person who sort of jumps on the couch and lays down like it is in the movie. So kind of have a Google or try to find some videos. But especially for young people and adolescents, therapy can look a little bit different than sort of just sitting in a clinic room. It can often be quite play-based and things. So I suppose presenting that accurate information, yeah, and sort of going with a try before you buy approach almost with the young person too.
Thank you. Now there's a question here for Holly or Divna around what the definition of maltreatment was in the Australian Child Maltreatment Study.
Shall I take that one, Holly? So we analysed 5 types of maltreatment: physical abuse, sexual abuse, emotional abuse, neglect, and exposure to domestic violence. And we counted anybody who had experienced any one of those as having experienced some form of child maltreatment, and someone who had experienced more than one of those different types as having experienced multi-type maltreatment. And there's a whole lot of extra information in terms of what we constituted emotional abuse, neglect, and things like that. Probably the easiest thing for those interested is to read our report, which we've linked in this resource page. But basically for sexual abuse, we had a whole range of different things, ranging from viewing things or being exposed to inappropriate sexual material right up to penetrative sex. With emotional abuse, it was about a pattern of interaction between parents and caregivers and children, and similar kind of levels for physical abuse. So we're able to look at severity as well as the presence or absence of particular types of maltreatment.
Thank you, Divna. And we can also provide links to all of the resources that everyone has mentioned. Kelsey, there's another question for you. What one of our participants says they've seen some instances where young teens have been influenced by friends who self-harm to use this as a coping mechanism. And is this something that you see commonly?
I think, you know, we do, as sort of behaviorism does suggest, we do, you know, we learn things off other people and the people around us. So I think it does happen. There's multiple things that influence it, but I think in terms of the antidote to it, I suppose, is really trying to have open conversations, because there's still something driving their behaviour. Whilst there might be something they've kind of seen someone else do, there's a reason why they are experiencing a level of distress that they feel self-harm is the solution to, I suppose. So whilst I'd say yes, it can happen, and there is, I think, research, don't quote me on this, but around sort of if that's happening in a peer group, the intensity and frequency. But again, I think it comes down to why is that individual doing it, and trying to get the support around them to help to mitigate that.
Thank you. Now there's a question here around, is there an intergenerational aspect to self-harm and suicide? Has anyone looked at that in their research, or Kelsey, in your experience?
Jessica, I'd answered that to say we're going to be looking into it, especially in the context that we now have intergenerational child protection data from you for our latest wave of linkage. So we will have information to know whether mum or dad was known to child protection services, and to be able to then classify families as those who may be, showing this intergenerational maltreatment, and whether the self-harm and suicidal ideation has also been an intergenerational thing we'll be looking into, but we haven't done that as yet.
There's also a question around siblings. So I don't know if ACMS looked at that, or Melissa, if you've looked at that as well.
No, we don't have enough siblings because ours is a child cohort of a one age group who entered school at the same time. Some of them have twins, but it's not enough. And if you did twin research, it would be very specific to twins. So we don't have enough siblings in our study to do that, but other linkage data might be able to look into that.
We didn't look at siblings at all.
Well, I think we're coming to the end of the questions in the chat, and almost the end of the hour, but I'd be interested if each of you had sort of one key takeaway message to provide to the group. What would it be? So I might go in order of presentations. If Holly, you wanted to start.
Yeah, look, absolutely. Oh, sorry, Jessica, you just cut out for me. Would you just mind repeating that?
Just if each of you had one key message from your work that you wanted participants today, particularly our caseworkers and others working directly with clients, but what would be your key sort of message from the work that you do?
Yeah, thanks, Jessica. Sorry about that. I think I don't want to encroach on Divna's part of our presentation too much, but I think just in terms of at least child maltreatment and self-harm that I presented, I think it just really demonstrates the strong association between child maltreatment and self-harm. As Divna mentioned, we basically see virtually no self-harm, or so little self-harm among those who haven't experienced child maltreatment. So in terms of presentations of self-harm, child maltreatment is most definitely something that needs to be at the forefront of anyone's mind.
Thank you. Divna?
Look, my takeaway message is probably not for the caseworkers, but it's really to invest in prevention, because I think we see so much government investing in health services when they're already presenting with self-harm, or they're already presenting with suicide. And really, I think we need to invest much more upstream to try and do that. For caseworkers, I think the takeaway is that impact of emotional abuse. So we know that sexual abuse is particularly damaging, but we've really underestimated the impact of emotional abuse. And we saw that across all of our other areas as well. So I think take the experience of emotional abuse just as seriously as you take sexual abuse.
It's a really good point. Thank you. Melissa?
Thanks, Jessica. And I'd echo what has just been said by Divna and Holly, but also point at interagency collaboration as a way forward in preventing suicide and self-harm among young people. But one of the key things that we find in many of our pieces of work using child protection data is that still very highly at risk of the things that are usually seen at their worst in the children who have been in out-of-home care. But for example, there's a health pathway program for children who are placed in out-of-home care. But that pathway program would not necessarily be in place for children with only a substantiated report who nevertheless were found in these records to have a self-harm or suicidal ideation incident. So perhaps a way forward there would be to offer those kinds of health pathway programs to other specific children with these kinds of profiles in child protection data. Doesn't need to be a blanket health pathway program for every child known to Child Protection Services. But clearly there are some very high-risk children. They're not in out-of-home care necessarily, but they do need some kind of assistance to get some health care at critical points in their development. So that would be my take home. Thank you.
Thank you so much. And Kelsey?
Cool. I will keep mine simple because the three presenters have done an epic job, and I agree that things need to happen at a kind of policy and systems level for that for change to occur too. But I just encourage people to have the conversation, to ask around it. We know it's prevalent, so it's probably more likely to be present for people who are distressed than not, for young people in out-of-home care. So have the conversation, get services and supports involved, but then also stay alongside them and help to target those drivers of distress, those psychosocial factors, which is so prevalent for kids in out-of-home care.
Thank you so much. And thank you everyone for joining us today. So everyone that's registered will receive an email with the link to the recording. I'd encourage you to share it with your colleagues. It has been a really, really important webinar today, and we'll provide additional links and materials as well. And we'd also like to invite you to our next Lunch and Learn research seminar on the 17th of October, which is our findings and recommendations from the family group conferencing evaluation. But again, I'd really just thank everyone today for your really important presentations and really useful advice, Kelsey. That was really useful, I'm sure, for everybody on the call. So thank you so much. And we look forward to seeing you again. Thank you.